Welcome to this explainer. Today, we're going to trace a critical care patient's journey through 4 absolutely fundamental, life-saving nursing interventions. We're breaking down the exact sequence of events that takes a patient right from the brink of respiratory collapse all the way to a safe, managed stabilization. Buckle up, because we're moving fast.
Here is our agenda for today. 1. The high-stakes ICU environment. 2. Rapid sequence intubation. 3. Confirming the airway. 4. Preventing ventilator-associated pneumonia. 5. Navigating IV fluid osmolarity. And 6. Critical care mastered. We're going to follow a strictly chronological path, going from acute, seconds-count interventions during intubation, all the way to calculated long-term stabilization.
Section 1, the high-stakes ICU environment. Every second counts.
So, let's step into the high-stakes world of the ICU. You know the scene. The environment is loud, monitors are alarming, the pressure is literally off the charts. When a patient can no longer protect their airway, whether that's due to severe pneumonia, a major trauma, or just a sudden deterioration, we have to move instantly to secure it. There is absolutely no time for hesitation here. Our primary overriding goal, rapid airway control.
Section 2. Rapid Sequence Intubation, or RSI, Pharmacology in Action.
All right, so what exactly is RSI? It's a highly coordinated procedure that uses specific medications to safely suppress a patient's reflexes and rapidly place a breathing tube. Now really notice that phrase, near simultaneous. We are not giving these drugs slowly. We're not titrating them to effect over several minutes. No way. We are giving them as rapid intravenous pushes to achieve immediate unconsciousness and flaccid paralysis. And this brings us to the absolutely crucial point, the golden rule of RSI. The order of operations. You must always give the sedative to induce unconsciousness before administering the paralytic. Step 1 is your sedative. Step 2 is your paralytic. Period.
But why is this order so critically important? Well, consider the alternative. If you paralyze a patient before sedating them, they experience the absolute terror of being unable to breathe or move while completely awake. And that isn't just psychologically devastating, it causes a massive physiological stress response. We're talking severe tachycardia, dangerous spikes in blood pressure, and heavily increased intracranial pressure. It's a worst-case scenario.
So to prevent that nightmare, we typically push an induction agent like etomidate first. Etomidate is fantastic because it rapidly induces unconsciousness and amnesia while keeping the patient's hemodynamics relatively stable. Then, immediately following that, we push a fast-acting paralytic like succinylcholine to induce flaccid paralysis and ensure optimal conditions for intubation. Succinylcholine gets to work in as little as 30 to 60 seconds.
Section 3. Confirming the airway. Purple to gold.
Okay, the medications are in, the provider has placed the endotracheal tube, but how do we definitively know it's in the trachea and not mistakenly down in the esophagus? We certainly can't just rely on listening to breath sounds in a chaotic, loud ICU. The environment is just too noisy, and sounds can be super misleading. We need immediate, visual, completely objective proof that we are ventilating the lungs, not inflating the stomach.
Enter colorimetric capnography. This brilliantly simple device is placed right between the resuscitation bag and the tube. The detector paper inside stays purple if the tube is in the esophagus because, well, there's no carbon dioxide in the stomach. But it magically turns gold when it detects exhaled CO2 coming directly from the lungs.
In the heat of the moment, just rely on this incredibly effective little visual anchor. Purple is bad, gold is good. Good is gold. Now, here is a really fascinating detail from our sources. You actually want to give it about 6 breaths before officially declaring victory. Why? Because if the patient recently chugged a carbonated beverage, the CO2 burping up from their stomach could actually give you a false positive gold reading for the first couple of breaths. After 6 breaths, any lingering stomach gas is cleared out and you know you've got a true accurate reading.
Section 4. Preventing ventilator-associated pneumonia. The long-term defense.
With the airways successfully secured and verified with that beautiful gold color, our patient has survived the acute crisis. Awesome. But our focus has to immediately shift. We now have to keep this patient safe on the ventilator over the coming days. The biggest long-term threat they face right now is VAP, or ventilator-associated pneumonia. This is a nasty hospital-acquired infection that strikes after 48 hours of being intubated. It's almost always caused by microaspiration, which is when contaminated oral and gastric secretions sneak right past the cuff of the breathing tube and settle down into the lungs. It can drastically prolong an ICU stay and seriously increase mortality.
So how do we stop VAP in its tracks? The absolute most crucial number to burn into your memory for VAP prevention is elevating the head of the bed to 30 to 45 degrees.
Maintaining that 30 to 45 degree angle simply uses gravity to physically stop gastric contents from traveling upward and microaspirating into the lungs. It's the cornerstone of the larger VAP prevention bundle. That bundle also includes meticulous, regular oral care to kill bacteria in the mouth, subglottic secretion drainage, strict hand hygiene, and constantly monitoring the pressure of the tube's cuff to make absolutely sure you have a tight seal.
Section 5. Navigating IV fluid osmolarity, hemodynamic stabilization.
As our patient stabilizes on the ventilator, we have to carefully manage their ongoing hydration and hemodynamics using intravenous fluids. Now, it might look like we're just hanging clear bags of water, but are all maintenance IV fluids created equal? Absolutely not. The precise chemical composition of the fluid we choose has profound, massive cellular impacts on our patient.
Check out the stark numerical contrast in osmolarity here. Normal saline, our standard go-to fluid, perfectly matches the tonicity of our blood at roughly 308 milliosmoles per liter. It's isotonic, nice and balanced. But look at D5NS, dextrose 5% in normal saline. Because of that added sugar, it is highly hypertonic, sitting at a massive 560 milliosmoles per liter. And this difference completely changes how these fluids behave inside the body. Normal saline just expands the extracellular volume. It stays exactly where you put it. But because D5NS is so intensely hypertonic, osmosis kicks in hard. It actively draws fluid out of the tissues and cells and pulls it right into the vascular space. Because of this powerful fluid shift, we have to monitor the patient extremely closely for signs of fluid volume overload and pulmonary edema. If their lungs fill up with fluid, our ventilator management becomes infinitely harder. Section 6. Critical Care Mastered. Tying the journey together. We successfully navigated the most critical phases of this patient's acute care journey, from the brink of collapse to stable maintenance. But hey, before we officially tie this all together, step right up. It is time for our rapid-fire 30-second nursing quiz to see what you retained. Ready? Let's play. Question 1. What is the ideal bed angle for VAP prevention? 30 to 45 degrees. Question 2. What color change on a CO2 detector proves correct ET2 placement? Purple to gold. Question 3. In RSI, what is the required order of drugs? You always push the sedative before the paralytic. And finally, question 4. What is the highly hypertonic osmolarity of D5NS? A whopping 560 milliosmoles per liter. All right, fantastic job, pencils down. Let's get back to our patient journey.
Tracing this timeline back out, from the precise pharmacology of RSI in those first frantic minutes, and the immediate airway confirmation just seconds later, all the way to the sustained vigilance of VAP prevention and calculated fluid management over the ensuing days. Every single intervention, every single decision, builds upon the last to save a life.
So this leaves us with a final thought to ponder. As our bedside monitoring technology keeps evolving, with better artificial intelligence, real-time hemodynamic tracking, and super advanced capnography, how will these core, foundational nursing interventions continue to adapt and improve patient outcomes in the future? The fundamentals we discussed today will absolutely always be the bedrock of critical care, but the tools we use to execute them, they're only going to get sharper. Thank you so much for joining me on this explainer, and keep learning.